So, welcome everyone. Thank you again for joining us today. We're so glad to have you here. And so, today's webinar is on inclusive cancer care for 2SLGBTQIA plus communities. So, we're so grateful that you are here and you're holding space with us today. And I'm very excited to have Kim Meeking here as well. And so, if we could have the next slide, I'd love to introduce you. So Kim is the co-lead of Queering Cancer, a grassroots project working to make cancer care more inclusive for sexual and gender diverse communities. With a background as a radiation therapist and a master's in clinical health research, Kim brings over 10 years of experience in oncology clinical trials, plus more than 5 years working in the nonprofit space. They're especially passionate about making clinical trials more inclusive and improving cancer care for SGD folks through community partnerships, meaningful research, and creative ways of sharing knowledge. So, Kim, welcome, and thank you so much for being here with us today.
Oh, thank you, Venetia. Thank you for the introduction. Welcome, everyone. Okay, let's get on. So I'm joining you from the East Coast on the traditional and unceded lands of the Mi'kmaq people on the Treaties of Peace and Friendship, which is also known as Nova Scotia. And it's a real privilege to be able to live and learn on these lands. Thanks again to Team Wellspring for their invitation to be here. I'm really glad you're here with me. I hope you're having a good day. Oh, you've already heard a bit about me, so I'll skip on. Okay, so just to start with, I've got some learning objectives for our session. We're going to talk about some of the common healthcare disparities that are faced by sexual and gender diverse people. And then we'll zoom in a bit and look at how that shows up in cancer care. And then we'll round up with some inclusive care strategies and advocacy strategies to help improve the experiences of folks in the community that are going through cancer care. And just a note, if you're watching and you're part of the 2SLGBTQ plus community and you're navigating cancer, heads up that in the first part of the session, I talk about some of the challenges that our community faces navigating healthcare and cancer care settings. And this might be difficult to listen to. It could remind you of your experience. Or it might not reflect your experience at all and still be a bit difficult to listen to. So either way, I just want you to feel able to put me on mute or take a break anytime you need it. And the latter part of the talk focuses on how cancer care can be improved and some support resources that can help. Okay, so I'm going to start off with some fundamentals so that we can all be on the same page. Now, when we talk about terminology to describe sexual and gender diverse identities, it's important to remember that definitions are not set in stone or meant to be prescriptive. The language is there to help us understand ourselves and each other better. Not everyone uses the same definitions, and that's absolutely okay. You'll notice that I use the term sexual and gender diverse and the acronym SGD. And this term is really inclusive. It encompasses all identities that are captured under various acronyms like 2SLGBTQIA+. You can see those terms defined on the slide. So sexual orientation, so this is the sexual, romantic, and emotional attraction that we feel for others. And we use terms like lesbian, gay, straight, or bisexual. Gender identity, this is our internal sense of gender. So this might be the same or different from the sex we're assigned at birth. And for this, we use terms like cisgender, transgender, non-binary, two-spirit. So everybody has a sexuality and a gender identity, but not everyone's is affirmed in healthcare settings. Okay, so there's a couple of concepts that I wanted to talk to you about, just in case you're not familiar. And the first is heteronormativity. Now, this is the assumption that heterosexuality is the only normal expression of sexuality. So, in other words, the belief that a man and a woman are the only people that should have romantic relationships together. And this can manifest itself in many different ways. For example, if you see a man and a woman come in for an appointment together, you just might automatically assume that they're married. The second term is cisnormativity. So this is the assumption that a person's gender identity matches their biological sex, the sex they're assigned at birth. And this can manifest itself in the form of misgendering, which occurs when a person is referred to by the incorrect pronouns or other gendered terms. And these two concepts are very much baked into healthcare, into the policies, the treatments, the environments. And it's one of the main reasons that it makes it so difficult to navigate these spaces if you don't fit into these societal norms. So Canada is home to approximately 1.4 million sexual and gender diverse people. And that's data from the 2021 census, so current figures are probably higher. SGD identification has become much more common in the last decade, with many younger adults seeing themselves as an identity other than straight or cisgender. Recent US data found around 20% of Gen Z identify as part of the community. And it's fair to say that most of us will encounter SGD people, friends, families, colleagues, and the patients, whether we know it or not. And this is a growing demographic. So the reality is, as this demographic gets older, there's going to be more sexual and gender diverse people navigating cancer care. So trans and gender diverse people have always existed across cultures and throughout history. On the slide, there's some identity labels from different regions across the world. Non-binary identities are also not new. They kind of predate westernized concepts of binary gender. And it's important to remember that colonization, particularly Western and Christian values, played a role in eradicating many trans and gender diverse identities across the globe. And sadly, we see that played out still today in the form of anti-trans legislation, threats to gender-affirming healthcare, rising violence against the community too. So gender transition and affirmation can take many different forms. People that are trans or gender diverse may not pursue the same steps. You have social transition, so this involves some everyday changes like using a chosen name or pronouns that match your gender identity, adjusting clothing or hairstyle, and being recognized by friends, family, or at work. Legal transition refers to updating identity documents such as health cards and passports. Hormonal transition includes gender affirming hormones such as estrogen, testosterone, or blockers. And these influence characteristics like voice, body hair, fat distribution, and muscle mass. There's also surgical transition. This may involve chest or genital surgeries, facial procedures, or other interventions. Not everyone chooses to take this route or has these options. And there are other important aspects to transition, like voice training, hair removal, also fertility preservation can all be part of gender affirming care. It's worth noting that cisgender people experience gender affirmation every day through their names, pronouns, and their appearance. So these things are usually recognized without question. For trans and gender diverse people, affirmation often requires an active effort and can be a risk. It's not always guaranteed that you'll be safe. And that's why inclusive and affirming care is so important. A little bit of history. So the SGD community face a long history of discrimination. In the late 1800s, being gay was labeled as a type of insanity. And around the early 1900s, Freud diagnosed same-sex attraction as neurosis. The American Psychiatric Association classified homosexuality as a pathology until 1973, taking until 2012 to declassify being transgender as a mental disorder. So-called treatments included aversion therapy, castration, and electroconvulsive therapy. And then in the 80s and 90s, the AIDS crisis further stigmatized queer sexualities. And although discredited, conversion therapy is still available globally and was only recently banned in Canada. Survivors often experience severe mental health impacts, with a third attempting suicide. In the next section, we're going to look at some health inequalities that impact sexual and gender diverse communities. Now, this is a big topic. We could spend a long time on this. There's been a lot of research into the health inequalities that affect queer and trans people. But the core underlying issues are stigma, prejudice, and discrimination. And unfortunately, this leads to many people in the community to experience something known as minority stress. So, societal level stigma and attacks on the community, especially the trans and non-binary community, leads to disparities in poverty rates, levels of violence faced, health outcomes, and access to health care. This population faces increased risk of some cancers and chronic conditions, and also suffers poorer mental health. And this is summed up by this quote by a patient, a lesbian affected by breast cancer. And she said, being part of a marginalized community brings additional pressures and stresses, and the anticipation of potential discrimination or everyday misunderstanding is always there. This creates additional burdens which impact health and well-being. She's very nicely summed up what minority stress is there. In terms of unmet healthcare needs, 45% of trans and non-binary people had an unmet healthcare need in the last year, compared to 4% of the general population. And this is data from the largest trans and non-binary survey done in Canada. There was nearly 3,000 participants, and obviously that is a significant gap. And this disparity is very much linked to the cisnormativity and heteronormativity that I mentioned, that is really baked into our system. This can mean that one negative experience in healthcare can really put somebody off engaging in the future, meaning that symptoms can become worse, and the avoidance means that in the end an emergency can happen. So we're going to zoom in now and have a look at how this shows up in cancer care for sexual and gender diverse people. I'm going to start off with screening. So SGD people are less likely to engage in routine screening, and there's several reasons for this. Many people fear discrimination or mistreatment in healthcare settings, and as I said, this can lead to delays and avoidance in seeking care. There's a generalized mistrust in the community because of the historical mistreatment. And this is compounded when it comes to intimate screenings like pap tests or colonoscopies, where individuals may fear discomfort or humiliation from the provider. A significant barrier also comes from healthcare providers, where they often lack understanding and confidence around SGD health needs. And this can mean missed opportunities for discussing cancer screenings with people that might be at an increased risk. Another issue is that screening guidelines don't very often address SGD needs. So SGD individuals are rarely aware of their own risks, and that can make it difficult to advocate for themselves. And there's some data on this slide from a 2020 study in the US. It's related to colorectal cancer screening, and they found a disparity of 29% of the LGBTQ community engaging in screening, compared to 65% in the state population. So because the lower screening rates and the barriers to healthcare, it's more common for sexual and gender diverse people to receive a diagnosis of cancer later, and that can mean that it's more advanced and harder to treat. There are also at least 7 different cancer types where the SGD community is thought to be at an increased risk. For example, Lesbians and bisexual women have a higher risk of breast and cervical cancer. Gay and bisexual men are 20 times more likely than heterosexual men to develop anal cancer. And gay men with HIV are at 40 times greater risk for anal cancer. And then for subpopulations like trans and non-binary people, there really isn't any reliable data because gender identity is rarely captured in the cancer registries. I'm just going to share a community story now to kind of give a bit of perspective on this. So this is Jennifer, and she's a young trans woman who had a history of fatigue and digestive issues. And she went to her family physician, worried about rectal bleeding. And this was before she started her transition. So in this instance, she was presenting as a cisgender male who was gay. And unfortunately, the physician that she saw dismissed her symptoms immediately, has said that she was too young for it to be for anything serious. And he actually put it down to anal sex. And this was a huge assumption and incorrect because Jennifer hadn't been having sex with anybody, any type of sex at this point. And this damaging assumption led Jen to kind of ignore the symptoms. She avoided going back, even though the symptoms persisted. And fast forward a year, she came out as trans and went through gender affirming care, and she was on some hormone treatment under the care of a team who noticed that her iron levels had dropped significantly low. And at that point, they referred her for a colonoscopy, suspected that she had a bowel bleed, and it turned out that she had stage 4 colorectal cancer. And obviously, if her initial symptoms perhaps hadn't been dismissed, she could have been, this could have been spotted a bit earlier. And when it comes to cancer treatment, undergoing surgery, chemo, or radiotherapy brings up several challenges for the SGD community. Again, they'll likely experience discrimination or uncomfortable interactions, fear of being judged, fear of coming out, fear of being misgendered. Healthcare teams probably won't be trained to recognize and address needs that are specific to the community. An example of this is chemotherapy and radiotherapy can affect hormone levels and interfere with gender affirming care. In this instance, you need these kind of risk benefit discussions between the patient, their oncology team, and their gender affirming care team to determine the right balance. But research in this area is significantly lacking, and these multidisciplinary patient-centered conversations often don't happen. What tends to happen is the patient is told that their gender-affirming hormone treatment has to be stopped, which obviously has a huge impact on how they navigate their life in their authentic selves. So it's common for cancer treatment also to affect sexual function and intimacy. Any patients may feel uncomfortable having these discussions, but it's generally harder for queer and trans patients, again, because of this fear of judgment and mistreatment. All of this to say that communication barriers are common, and not being able to be open with the healthcare team leads to feelings of isolation, unmet needs, which can impact outcomes after treatment. When it comes to survivorship, SGD patients have to adapt to this identity as a cancer survivor, integrating it with their other identities. And there's evidence that layering of these identities on top of being queer can compound psychological distress. After cancer treatment, queer and trans people are more likely to experience poor mental health, health-related anxiety, and also chronic health conditions compared to cisgender heterosexual counterparts. And of course, navigating survivorship often means continued courses of treatment, aftercare, and follow-ups. And there's still very little tailored support, leaving patients feeling isolated and having to really self-advocate. An example of this is Tristan's story. So Tristan's a trans man and ovarian cancer survivor, also an amazing community partner with Queering Cancer. So Tristan needs a specific type of blood test to ensure that his ovarian cancer is in remission. And important to note that Tristan's gender markers on the health record system and all his documentation are male. When he goes to the lab to get this blood test that he needs, which is specifically for ovarian cancer markers, the test is coded for females only. So Tristan's blood test gets cancelled and he gets sent away from the clinic. And this happens repeatedly. It delays his follow-up care, causes a lot of anxiety. And he ended up advocating for the lab request system at this hospital to be changed so that it could allow tests to be available for anyone that needs them, regardless of gender. He ended up changing the system in the whole province because of this incident. But I think important to note that he is an oncology social worker. He's kind of familiar with the system and could do some of this self-advocacy from the inside, if you like. But honestly, it shouldn't have been his issue to solve. And when it comes to end of life care, sexual and gender diverse people continue to face many barriers. They often access care late or not at all. SGD people fear that entering a care facility might mean going back in the closet. And we know that adequate care at the end of life depends on really meaningful communication about a person's hopes, fears, wishes, sense of self, and values. And holding back who you are at this time of life would clearly impact comfort and dignity. Queer and trans people also fear that their chosen family may not be respected or recognised as next of kin. And within this, partners also feel unsupported in their bereavement. And another community story. So this is David's story from a 2016 report in the UK. As he says, I knew he wanted a burial. He wanted to be buried next to his mother. He ended up being cremated, which was totally against his religion. I couldn't stop them, but it was like strangers organising his funeral. I was his family, but he never wanted it to be known that he was gay, and I respected that. If he wasn't out, I wasn't out either. I couldn't talk to my family. They thought David was just a friend. It was a right mess, and I had nobody to turn to. I mean, what an extremely isolating and sad experience that must have been and impacted the last of their time together. In so many ways, this could have been a better experience. And we're going to take a look at that now. So the next few slides will be more about how we can integrate inclusive cancer care. And I've broken this down into looking at communication, environment, and also the intake process, because that's an important kind of time point in the journey that can make a big difference. So first off, inclusive communication. So really this relies on not making assumptions about someone's gender, sexual orientation, relationships, or body parts. It's really helpful to use open-ended questions like who is with you today or who can help you come to your appointments, rather than making assumptions about relationships. Another tip is to neutralize gendered terms. So this means swapping gendered terms like man, woman, husband, wife with gender neutral alternatives, patient, person, partners. So this can be a real game changer if this adjustment is made, but it takes quite a lot of practice. And one tip, if you need to discuss a patient and you don't know their gender identity, is you can use the singular pronoun they when you refer to them. So you can say, they are here for their appointment. Again, this takes practice, but you can make these changes and kind of address some of the automatic assumptions that you might make. Another good tip is to listen to the language that the patient is using to describe themselves and their loved ones. And then you can mirror that language. And obviously, if you're in any doubt, you can ask the patient what terms they prefer you use. On the topic of inclusive communication, I just wanted to mention misgendering. So this is when you might wrongly assume someone's gender, use the wrong pronouns or other gendered language. For instance, calling someone sir because they look masculine and you assume that they're male. It can happen intentionally or unintentionally, but either way, it's harmful. And I experience this from time to time. People call me sir, my short hair, and make an assumption. And if anything, for me, it feels embarrassing because I have to then make a correction or decide whether to correct them. And over time, it can build up a little bit like kind of paper cuts. These are called microaggressions. But if you do misgender someone, don't panic. This is my advice, just apologize and move on. Don't over apologize. People tend to do that. And then just commit to doing better. So maybe just in internal dialogue, you can see how you can stop that happening again. Try and catch those assumptions before you say anything. And it's useful for allies and members of the community to know and use respectful terms. And here's just some examples of terms to avoid and what to use instead. So the word homosexual, so this has got a real clinical history. It's often used as a slur, and it links back to the idea that gay people were diseased or had a psychological disorder. And these ideas are long discredited. So instead, you use terms like gay, lesbian, or use the acronyms 2SLGBTQ plus or SGD. And likewise, don't say things like homosexual couple, just say couple. If it's necessary, you could say same-sex couple, but question whether it's really relevant to name the sexual orientation. Avoid saying sexual preference. So this implies that being attracted to the same sex is a choice and leads to the assumption that it could be cured. Instead, use sexual orientation. This is an inclusive way to say it because all orientations, including straight people, this applies to us all. Don't say a transgender or someone is transgendered. There's no need to add the ed on the end. Instead, you can just say transgender or trans. And avoiding terms like sex change. This puts a real emphasis on surgery to transition. It's a really good practice to avoid emphasizing this. If you have to use a term to describe transition, then just use that transition, and that encompasses all different types of transition that we saw earlier. And last of all, just try and avoid saying biologically male or biologically female. These are problematic because they really oversimplify. So it's better to use assigned male at birth or assigned female at birth. Okay, so moving on, I wanted to talk to you about welcoming environments, inclusive environments. So as a queer person, one thing I do if I enter a space, especially one that's stressful, like a clinic in a hospital, is scan it for signs of safety. So a rainbow sticker on a reception desk or a safe space poster displayed on a pinboard can indicate to me that I can let my guard down. If I see somebody wearing a rainbow lanyard or a badge or pronoun pin, that's another signal that I can let my guard down. And I immediately feel a sense of relief. And I just hope that I get called in by that person. There'd be a safe person to come out to. One thing to be aware of, though, is performative allyship. So sometimes you can walk into a space and see a rainbow sticker, but it might not be backed up by appropriate education or policies. And in that respect, these are false signs of safety, they can actually be harmful. So it does mean that if you're in the community, you can be a bit wary of rainbow stickers, but on the whole, it's seen as a positive sign. And the one on the slide is downloadable from Rainbow Health Ontario. So earlier I talked about barriers to taking part in screening for the SGD community. Often screening campaigns are highly gendered and they don't usually feature um, sexual and gender diverse people. And this sends an unintended message that this is not really meant for us. The same goes for patient information, images on websites, representation of patient stories and testimonials. More inclusive patient materials would feature a mix of identities, so maybe some same-sex couples or trans and gender non-conforming people. And now the examples on the slide are from two different screening campaigns from a charity in the UK called Outpatients. And these are targeted campaigns to try and improve screening rates in the community, one for cervical cancer and one for breast cancer. I just want to touch on inclusive intake processes. It's quite often this is the first time a queer or trans person will have an interaction in a healthcare clinic, and that first point of contact can be really crucial in setting the bar and kind of embedding some trust. So when it comes to designing systems, forms, and processes, they should consider the needs of everyone that's using that service, including sexual and gender diverse people. It ensures that all patients feel respected and included. It supports accurate data collection, which really helps researchers address health disparities. As I said, it builds trust and helps to reduce barriers to healthcare. So what are these inclusive intake processes like? So firstly, they would use gender neutral language. Some of the adjustments that we saw on the earlier slide, like using parent, spouse, partner. They would provide a space for people to share the name that they go by, as well as their legal name, because they may be different. They'd provide a space for people to share their pronouns. They would include intersex as an option when listing sex. They'd include non-binary and two-spirit as gender identities, and avoid using other as an option. And instead of other, just using kind of a free text option for people to self-identify. And importantly, unless it's medically relevant, all of these questions should be optional so that people don't feel forced to disclose. In this part of the session, we're just going to talk about how SGD patients, families, and allies can advocate in cancer care. If you're here as an ally, it's important to understand how hard self-advocacy can be. For many queer and trans people, especially trans people of colour, speaking up in healthcare isn't just uncomfortable, it can feel impossible. When you add the stress of a cancer diagnosis, and the appointments, procedures that come with it, the pressure to keep standing up for yourself can become exhausting. So we're going to look at how we can reduce that burden, what tools are out there to support the community. So first of all, for patients, bringing a trusted support person with you to appointments can provide emotional backing and advocacy. They can do some of the heavy lifting when it comes to guiding providers on language and terms that you prefer to use, like correcting pronouns, explaining chosen family relationships, or even preferred terms for body parts if certain anatomical terms are difficult for you. Patients and their support people should always be able to ask what a clinic or a department has to be able to support queer and trans patients. This might be non-discrimination policies or gender-neutral washrooms. You should always feel able to ask these questions. And lastly, grounding techniques can be really helpful. So maybe you could make a short list of things that help center you in times of stress. Maybe it's breathing exercises, visualization, photos of people or places or pets that bring you a sense of calm. Maybe a list of trusted people that you can text if you need a bit of support. Families, partners, and allies have such an important role to play. And one of the simplest but most powerful ways to show up is by using the correct name and pronouns every single time. It may seem small, but it makes a huge difference in affirming someone's identity. Allies can show up by coming along to appointments and helping make sure their loved one's voice is heard. It's important for allies to take the time to learn about 2S LGBTQI health needs and histories. So thank you to any allies in the room that have shown up today. Advocacy is not only for individuals, but it's collective. Community groups can have a lot more impact than marginalized voices. Communities can push for inclusive policies in hospitals and clinics, from intake forms to training. Sharing of stories in community can raise awareness, reduce stigma, and connect people together. Provided there's safety in sharing those stories, it can be really powerful for learning and support. And supporting organisations that are dedicated to SGD cancer care really strengthens what they're able to do. So if you've got a platform where you can help spread the word about queer and cancer, please do so. And if you need any help with this, you can just get in touch with me. So lastly, some support resources that might be helpful. So Wellspring offers two groups for the community, one with a gay men's focus and one with a gay women's focus. Both groups welcome trans and gender diverse folks too. And these are held once a month online and can be found at wellspring.ca. The Sexual and Gender Diversity in Cancer Care programme is based at Princess Margaret Cancer Centre in Toronto. They have a website with some scenario-based training, which can really help to improve knowledge and confidence in inclusive communication. I would recommend this for healthcare professionals, but also friends and family that want to be able to practice more inclusive communication without a fear of making a mistake. This group also has in-person support for queer and trans cancer patients at Princess Margaret, and they can be found at pmchosenfamily.com. And last but not least, this is us, queerandcancer.ca. You can visit our site to find a collection of patient stories, a list of community support options, including support groups and forums tailored for the SGD community. We've got patient information that's tailored for the community and also provider education. We're at queerandcancer.ca. And that's the end. So I just want to wrap up and say thank you very much for being here. And I hope you take one or two things from the session and feel a bit more equipped in your personal journey or in the way that you can support queer and trans non-binary folks that are in your life. And thank you again for the invite. I've got a few resources and contact details on this slide, so I'll leave it up for a second. And welcome any questions.